we're going to start. I'd like to welcome you from all regions of the world, no matter what time zone you're in. Thank you for tuning in. It's early in the morning in the Americas. It's in the afternoon. Good afternoon if you're from Europe, Africa, or the Middle East. And good evening if you're tuning in from Asia. And if you're connecting from all the way from Australia on Oceania, I applaud you for staying up in the middle of the night, and thank you for connecting also from those regions. So my name is David Schieffelers. I've been heading up and leading the steering committee of World Burns Week as part of the Burns Working Group of the G4 Alliance. Now, just a quick word about World Burns Week in and of itself. World Burns Week exists because we live in a world where, you know, your income level and the location where you live are the two main factors that determine whether you sustain a burn injury or not. And sadly, we also live in a world where the countries that have most of the burn injuries also have the least amount of resources for burn prevention, burn care, and aftercare and survivorship. And so we wanted to dedicate 1 week to address these global inequalities. By collaborating, by learning, and by raising awareness and advocating for equity along the entire continuum of burn prevention, burn care, and survivorship. And this is what we've done. And so I'm really happy to welcome you and to announce that we've succeeded in forming a global collaboration of so many different actors and organizations that are involved in burns. I want to thank particularly the founding organizations that are represented on the steering committee. And I also want to thank the many endorsing partners that we have. There are too many for me to really list and count, but they're all listed on our websites. And it's those partners that have altogether supported us in making World Burns Week a reality. So this year, we are approaching burns as a hidden global health crisis. And just to show you, we also have a PowerPoint slide for this. So we're really approaching burns as this hidden global health crisis. And throughout this week, what we want to do is take you through different sort of like chronological sub-stages of that theme, right? So first, today, we're going to look at the current state. On Tuesday, we're going to look more at the hidden costs. On the Wednesday is about the common responsibilities. The Thursday, the solutions. And Friday, we're going to tackle or talk about commitments, right? So I hope that you that this excites you, I'm really happy that after 1.5 years of planning, you know, it feels a little bit surreal to see this coming together, but we've succeeded. And you know, this is one of the first times that really all these different burn actors and organizations and entities have come together to rally behind a common cause. And it's an important one, and I hope that you can come alongside us and agree with that as well. So with that being said, it's my pleasure to open the first ever inaugural World Burns Week. So welcome, and without further ado, let us start this Monday webinar session organized by my colleagues from the ISBI and ANSPA. Michael, Siobhan, over to you.
Thank you, David. My name is Michael Serghiou. I'm the Executive Director of the International Society for Burn Injuries, and I want to welcome you all, friends and colleagues from around the world. And like David said, good morning, good afternoon, good evening to everybody, and thank you for attending. The International Society for Burn Injuries wholeheartedly supports this inaugural World Burns Week. It is an incredible effort, like David said, that started over a 1.5 years ago, and we fully stand behind it. Never before, in my opinion, so many burn care entities and organizations from around the world have joined forces to work on a project like this. This week, starting with today, we're gonna work on we're gonna look at the current state of the problem. We're gonna better understand it. We're gonna exchange ideas on how to tackle this serious problem that affects especially resource-limited environments around the world. And finally, we want to commit at the end of this week in a meaningful way on how we can bring solutions and how we can make a difference in improving burn care around the world. Again, I welcome you all on what's promising to be an exciting week. And I want to turn it over to my co-moderator, Siobhan, from the Australian and New Zealand Burn Association to carry on.
Thanks, Michael. Hello, all. I won't say good morning. It is 1 a.m. here, but welcome from all of the places that you are coming from. My name is Siobhan Connolly. I am the Chair of Prevention for the Australian New Zealand Burn Association and sit on their board. And like Michael, ANZBAR is very committed to World Burns Week and what we can achieve, and moving forward, what we can all achieve together. As I like to say, let's put ourselves out of a job. Let's see what we can do to reduce the numbers, reduce the effects, and support everyone across the world. So I want to start off today, day one, as the current state. We're going to be talking about what is happening in burns at the moment, what can we do, and setting the week up. So I hope David is going to advance my slides. We might jump through the next two, David, to number 4, please. So I just wanted to quickly touch on a few things, just go back maybe to yeah, that one. So obviously there are a lot of burns that happen around the world. To me, this is striking, looking at exactly what sort of numbers we're talking about. So up to 12 million people a year, 33 a day, and 20 a minute. And most burns are preventable. And I think we need to remember that and what we can do in regards to that. Next slide, please. So in 2018, WHO reported that burns are 7 times higher in the LMICs than the HICs, and a lot of that is predominantly in the sub-Saharan Africa and Southeast Asia. There was a study done in 2023, and we are amazingly privileged to actually have 2 of the people from that study presenting today for their areas, and they're going to highlight some of the issues that they found in the study, and also what suggestions and what we can do. And just to quickly touch, if we go to the next slide, on a few things that came up, and I don't want to give away the ending for Dorothy and Shobha, but there were a few things that really were highlighted in this study, which are from the African countries, but carry across the world, really, if we look at it. So when we're talking about burn care, it's more than just dressings and operations, and a lot of people think about that when they talk about burns. But particularly from an LMIC point of view, there are some issues like staffing and medical equipment and infrastructure that we really need to support our colleagues, to support the rest of the world, so that we don't have these discrepancies, we don't have these issues, and we are going to have some fantastic presentations. And then obviously things that we can do to support are more education and more prevention, enhance our colleagues and help them as much as possible. Next slide. Very, very quickly touching on what we're talking about. So the theme for today is looking at the fact that, yes, there might be 20 burns a minute, but it is really more than just a number. What we're talking about is so much more than that. So next slide, please. So we do actually have a few fantastic presenters for today. I will pass on the apologies of Dr. Semesa Matanaicake from Fiji. Unfortunately, he hasn't been able to join us today. He is one of our surgeons from the Colonial War Memorial Hospital in Fiji, and I've been privileged to work with him and other people across the Pacific in a lot of burn care. And I have to say that it's an amazing honour and a learning situation. whenever we go to one of our Pacific colleagues, because the amazing activities that they do teach us every time. I was lucky enough to work in Vanuatu, and I have to say it showed how very, very privileged we can be and how some simple measures can mean so much from our colleagues. So without further ado, I'm going to pass back to Michael to introduce our first presenter.
Thank you, Siobhan. Before we go on, I just wanted to let everybody know to please, if you have any questions or any comments, please write them in the Q&A box you see on the bottom of your screens there, so we can have some discussion at the completion of our session today. So without any further ado, I want to introduce to you Dr. Shobha Chamania. She's a general surgeon for over 40 years. She currently works at Chongran Hospital in Indore, India. She is one of the co-founders of Interburns, and we're going to be hearing from Interburns later on this week. And it is my privilege to introduce a great surgeon and supporter of this effort, Dr. Shobha Chamania. David, can we please go to the video?
Good evening to all. I want to thank the organizers of this conference to have invited me to participate in this very interesting topic and the celebration of the International Burn Week. I'm happy and privileged to be a part of this program. I'm Shobha Chamania, Senior Surgeon from Choithram Hospital and Research Center, involved in burn care for the last 40 years. And I'll be sharing with you the current status of burn care in India. We all know that Southeast Asia is one of the places with highest incidence of burns. But how big is the problem? Sorry. How big is the problem? It's more than 1 million people affected in 1 year in India. And the reason, as is well known, even in the developed world, is the poverty, illiteracy, and their low safety consciousness. Their whole environment, social structure is such that they are prone to sustain burn injuries. Burn care in India is multifaceted and it is influenced by social determinants of health. So how high is the burden of burns in our country? Is about 1.9 million, and the prevalence is 1.5 million fire-related injury with 23,000 deaths in 2019. Women are supposed to be affected more because of unsafe cooking, kitchen practices, and also related to domestic conflicts and violence. Men are affected at work, and this leads to a lot of economic burden for the days lost without work, and it's a challenge for this developing country. Majority of children sustain burns at home. Okay. What are the challenges of this country? The burn care started in 1960s, and this was centralized in big cities like the metro cities, mostly Bombay, Delhi, and Chennai. Whereas the 66% population, in those days, more than 70% population lived in rural areas. where the healthcare delivery system is fragmented and their injuries are common because they are even warming the bathing water on open flame. So the infrastructure over the years today has improved in select public hospitals to provide care for these patients, such a large number. And many standalone private and corporate setups have come up to offer standard of care for burn patients, especially the major burns. If we call this decentralization, then this has happened, but has been sporadic. It is not enough to take care of such a big challenge. Therefore, the key challenge is timely and adequate access to health systems. And the main reason is the main reason of delay is inefficient referral systems. Do we have adequate burn care services? Coming to numbers, we have 67 significantly large committed burn care facilities in the country, 30 in public and 37 in private. The rural healthcare workers have been given some basic training, but their contribution to managing minor burns is very limited still. There are 1339 beds for burns and only 300 beds in ICU for burn care. So this is catering to 16% of population that lives within 2 hours of approaching this facility, mostly centralized. The remaining population has to wait and find out where it is and then try and reach there. Of course, approaching how to do it, where to go, do we have enough money to get the treatment? And these are the questions in their minds. Do we have adequate medical equipment? Is the other question, and medical equipment is in terms of burns, ICU is adequate. These are the centers of excellence. They have adequate trained people taking care, all the monitoring equipments, and almost everything is state of the art is available there. Early surgery has become a standard of care in these centers of excellence, and therefore their survival of major burns is improving. We are happy to share that. But the challenge is affordability of these services because most of it is out of pocket. There is now a lot of insurance coming up. Mostly the industrial people have insurance or the industry pays for it. And the government has provided some aid to support the treatment in this. Coming to prevention of burn injury, because it is a preventable disease, we should be able to prevent the high incidence of burns in our country. I think that should be our primary aim. And most of the clinicians who are in practice of burn care have been making efforts in their regions to spread awareness using all kinds of methodologies that are available today and all platforms that are available today. This has been recently picking up the interest of all the persons treating burns. But I think we need a good public health approach to reach the masses, because despite all the efforts of the clinicians, public still continues to be ignorant about prevention and first aid, which is a sad story. Prevention strategies that are based on education have to be repetitive to be effective, and this only should be very briefly telling them what are the risks and how can you protect yourself from those risks, and what is the best first aid for burns at your workplace, at the place of injury. Secondary prevention talks about good first aid by pouring tap water over burns. It has been popularized for more than 6 decades now, but we still do see patients not using this, and about 20 to 25% burn cases use this first aid very nicely and have good outcomes from there. This is a picture showing the National Prevention Program that was rolled out in 2010. And the government started capacity building in some pilot areas in some states where the infrastructure was radically improved, training of people working there, and their salaries were better so that they were motivated to work in those areas. And this led to a lot of improvement in the burn outcomes. Next 5-year plan, they were to roll out in all the green marked areas, which is about 75 centers. We have not significant reports from these centers how much improvement has really taken place. The focus was to reach out, decentralize the care, and reach out to the rural masses and in the district places so that the care is better, patient doesn't have to travel so much. And it is still unfortunate that we have not reached there. We have a lot of deformities and therefore surgeons organize a lot of reconstruction camps and survivor groups to identify who needs help and what kind of help. And they are organizing through various social organizations using government funds available. And therefore, this public-private partnership is helping us to reduce this problem of deformities and scarring. The common causes of burns in India are, amongst the flame burns, are these unsafe stoves and unsafe lamps that are used for illumination. And this is another which is a very historical picture. Of course, the flammable fabric still goes on, and the electrical cables that are not underground, and the workers who go to repair these cables do not use safety measures, and therefore they succumb to injuries. What are the passive strategies that we have used? One of the very successful passive strategy has been the ban of free sale of acids. The government had passed a legislation, and this was enforced and has seen a big impact in reducing the number of acid burns. Of course, we have seen a lot of firework burns used to happen in Bbaale, which is a festival celebrated in November. And this also a lot of active preventive strategies were done to prevent firework burns. Students were educated, children were educated that this is not a safe way of igniting it. And big cities also mentioned a lot of reduction in the incidence of firework burns. Engineering designs at home to reduce some burns. We have some success stories here. The lamp, which was an unsafe lamp based on kerosene and open flame, we picked this up from a community, educated them, and then distributed some solar lamps or LED lamps, and went back after 1 year to see the lamps were still working. They were happy with the illumination it provided, and there were no injuries, accidental injuries. During this 1 year, there was only one case of self-harm of burn. For childhood burn prevention, we created this barrier in a 2-room accommodation in a low socioeconomic community. And in 1-room accommodation, we had provided a playpen so that the children can be kept away from the cooking area and the mother can be at peace. This also was successful, though the size was very small and the duration was only 6 months. But we saw a great reduction in the burn injuries. What is the need to manage such big incidents of burns? And unfortunately, it's not only numbers, but we also get very large and extensive burns with very deep burns because the first aid is not effective. We need a burn fellowship 1-year course to train the doctors and the team so that we have specialized care nursing and trained team members who can manage pain, and we need infectious disease consultants in this country to stop the misuse of drugs in burn care. So summarizing, the way to go forward is to advance all 3 important sectors: prevention, management, and rehabilitation, so that once the incidence is reduced, the burden is reduced, the severity of the injury is reduced, then we can definitely manage this. This will also take care of the delay in arriving at the center of care. Staffing is the most challenging area in burn care. Nurses must work hard because the ratio in India is much smaller as compared to the developed world, and the number of patients they have to manage are larger, and their salaries also do not really motivate them to continue to work hard. Therefore, the attrition rate is high, and they are attracted towards better career prospects. Therefore, they leave. Junior doctors change frequently, so the only constant members of the team are therapists, psychologists, dietitians, and dressing technicians. We need to have more trained individuals to build the capacity to take care of such a large incidence. Thank you very much for your patient listening, and I'll be happy to answer any questions. Thank you.
Thank you very much, Shobha. So an amazing presentation. Now, just before I pass over to the next presenter, I just wanted to quickly say my apologies. We didn't remind people that you could have translations. So if you look down the bottom of your screen, David has put a message in different languages in the chat. I won't attempt the different languages, but there are captions that you can get translations. And also, although we have recorded the lectures for today, we do actually have our presenters in person to answer questions at the end. So hopefully you can stick around and we can have a bit of a chat at the end. So our next presenter is Dr. Dorothy Bbaale. She's a plastic and reconstructive surgeon from the Bbaale Children's Hospital in Malawi. And again, she was one of the authors on that paper that I was talking about. So we're very privileged to have Dorothy join us and do a presentation. So we will hopefully show you the presentation in a moment. Thank you.
Hello, everyone, and thank you for joining us for the first day of World Burns Week. My name is Dorothy Bbaale, and I will be going through a survey where we try to understand what's the state of burns management in Africa, some of the challenges and solutions that the healthcare workers are facing on the ground in different African hospitals. So as you probably know, or you have heard from some of the other talks, the people mostly affected by burn care or by burns are the people coming from low and middle income countries, especially the pediatric population. And we have a considerably higher mortality and morbidity rates in comparison to high-income countries. Some people have tried to understand what could be some of the associated factors that could be leading to these high mortality and morbidity rates. And it basically boils down to poor socioeconomic status, traditional beliefs, as well as delayed presentation of patients to healthcare facilities. Also, a limited availability of resources has a huge impact on the eventual outcome of these patients. For many years, burns have been called the neglected or forgotten epidemic of the world. And we think this is also mainly due to the fact that till date, many African countries do not have official burn registries that could have helped provide the necessary data to help bring the situation to light sooner or earlier. So we carried out a cross-sectional study where we sent out an online survey to healthcare workers involved in burn care management in different African hospitals over a period of 5 months. And we had a generally good response with more than 300 participants responding to our survey. However, when we went through those questionnaires, we were left with 271 valid answers and from 40 different African countries. And as you can see from the map, it was actually quite a generally good response, with only the countries that are in white where we failed to get any kind of response at all. So I'm just going to take you through some of the interesting facts that we found from our study. Majority of our participants worked in tertiary health facilities and governments or public institutions. So you would assume that these institutions should be pretty well staffed and well equipped. However, we found out that only 48.3% of our participants said that they have 1 to 3 specialized physicians working in their burn care teams. And they're greatly supported by non-specialized physicians or general practitioners, as well as the nursing staff. When it came to allied professions, only 58.7% of the respondents said they had at least 1 physiotherapist as part of their teams. However, when it came to other professions such as psychologists, occupational therapists, and nutritionists, many of our respondents said they do not have these members as part of the multidisciplinary team. Concerning infrastructure, only 34.7% of respondents said that they actually have a separate burn unit in their hospitals, and with a mere 21% saying that they had separate burn ICUs. From this slide alone, I feel like it helps highlight the gravity of the situation on the ground. We do not have enough hands on the ground in terms of human resources, where we have less than 50% of our respondents saying they have specialized physicians helping to manage burn patients. And moreover, they do not have the adequate number of allied health professionals to help support their burn management teams. Moreover, as you can see, very few actually have the correct facilities that patients need, where patients need to be treated in. And this can make you understand that even though a patient might actually get to a hospital on time, there's so many internal challenges within the hospitals that they go to in terms of lack of human resource, as well as lack of adequate infrastructure. We were also interested in understanding after that, okay, do we have enough resources and equipment? And as you can see, when it came to the basic materials such as sterile gloves and dressing materials, there were adequately, most hospitals had enough equipment. But when it came to the more specialized equipment such as ventilators and fluid resuscitation perfusion systems, less than 50% of our respondents said that they have access to such equipment. Skin grafting is the life-saving procedure that you need to perform on a patient who's had a major burn. And what was interesting was that almost a third of our respondents said that, well, they do not perform skin grafting routinely. Moreover, less than 40% of them said they actually even have the correct equipment that they need in order to perform this life-saving procedure. So apart from a dire lack of human resources and infrastructure, we can still see that equipment is also a major problem. We were interested in also understanding what are the outcomes. Due to the fact that we do not have so many things, what are the outcomes that we would expect from a patient who's had a major burn? So we asked them in terms of what are the chances of survival after having a major burn would there be? And as you can see from the two last paragraphs, basically, the larger the burn, the higher the chances of mortality, where you can see clearly in the last paragraph, more than a 60% burn surface area basically would mean that there was more than a 50% chance of mortality. We took these predictions of outcomes and tried to understand if there was any correlation or any association with other factors that we had tried to elicit through our questionnaire. However, what we interestingly found was that there was a direct association or correlation between the Human Development Index of a country and the outcome of a patient. So the lower the Human Development Index in a country, the higher the chances that patients would have a poor outcome. We then asked our participants to cite some of the reasons for poor outcome. And the leading reason that was cited was late presentation due to previous treatment, maybe by a traditional community healer. Apart from that, they did also cite many internal challenges that they do face, also leading to possible poor outcomes, such as lack of infrastructure, as you can see, lack of intensive care units, lack of theater space, lack of trained staff, and also lack of equipment to be able to perform skin grafting. When asked about the potential areas for improvement, many cited that improved and more infrastructure and equipment would greatly improve their outcomes. However, also you can see that there's an interest in improving the local capacity or improving the education of the local staff in skin grafting techniques and also overall burn management education. So in conclusion, I think our study highlighted many things, but in conclusion, you can see that it highlighted that there's still a grave lack of adequate human resources to be able to manage these manage major burns adequately. And this can be seen with the fact that there's grave difficulty in trying to form a proper multidisciplinary team with all the members of a team present in many hospitals. There's still a great lack of infrastructure. Many of the institutions don't have separate burn units. Moreover, they do not have also separate intensive care burn units. And also this lack of equipment means that they cannot routinely and also perform timely skin grafting for their patients that do come to the hospital on time. The survey shows also that there was also a strong association between the Human Development Index and also burn-related mortality, which once again proves the importance of how we need to, emphasizes that there's a great need to improve the overall quality of burn care that is being administered and being received in low and middle income countries. However, I would like to mention that these answers or these responses were perceptions and the thoughts of healthcare workers on the ground, and they do not necessarily represent the actual facts, maybe, and it's due to the fact that we had an inadequate amount of responses from some countries. It's not entirely representative of the situation in all African countries. Thank you.
Thank you. Thank you so much for this excellent presentation, Dorothy. Next, we have Judith Cato Addison from Ghana. Judith is a burn survivor, and she's also the founder for Beyond Burns International. David, can we please go ahead and play Judith's video?
Burn injuries are very common in Ghana. Household burns make up a huge percentage. This is likely because approximately 80% of households use open fires with biofuels like firewood and charcoal for cooking. Also, many households do not have a separate kitchen from their living areas. Our traditional cooking stove, which we call the coal pot, is at about a height of less than 2 feet, within easy reach of children less than 5 years. It is therefore not surprising that greater than 70% of all pediatric burns occur among children less than 5 years. The burden of burn injuries on burn survivors begin from the inpatient phase and ranges from physical, nutritional, psychological, financial, and social. The treatment process is long, painful, and expensive, and many are not able to afford these basic necessities of burn care. I remember many instances while I was on the ward where I had to share basic wound care items like cotton wool and gauze with other people because they could not afford. Some patients had to bear the discomfort and potentially risk infection by stretching out wound care dressing to 5 to 8 days because they could not afford optimal care. Apart from wound care, purchase of medications is also a problem. Even at the point of discharge from the hospital, some people have to rely on the benevolence of a few individuals and nurses to pay up their hospital bills. Follow-up after discharge from the hospital is also a challenge. Some survivors have to travel long distances to reach appropriate health facilities for review. The transportation cost and cost of follow-up laboratory tests pose a huge challenge for burn survivors. Additionally, post-burn rehabilitation services like physiotherapy and psychological support are very few, far between, and very expensive. These services are so limited that many doctors don't even bother referring underprivileged survivors to them. Another major challenge burn survivors face in our part of the world is stigma that comes with deformity. Many burn survivors suffer scarring on various parts of their bodies. Sometimes these scars are very disfiguring. There's very little education on this, and there's a sparsity of trained social workers or advocates for survivors in the communities. Coupled with some traditional cultural beliefs of deformed or disfigured people being non-human, burn survivors with disfiguring scars suffer both societal and self-imposed ostracization. Essentially, their lives as members of the community, be it school, work, employment, relationships, marriage, all come to an end. We have a national health insurance scheme in Ghana, which in writing should cover reconstructive surgeries. However, in reality, the scheme only supports burn survivors with less than $3 a day for adults and $1 a day for children, using current exchange rates, of course, and which has a cap of less than $70 maximum cover per person for the period of admission. This in effect covers the cost of accommodation on the ward for a maximum of 1 month. It does not cover medication, feeding, surgery, anesthesia, wound care, psychological rehabilitation, physiotherapy, movement aids like wheelchair, adjuncts like eyeglasses. It doesn't cover any of this. A burn support group has also been started, a government hospital initiative at the Reconstructive Plastic Surgery and Burns Unit of the Korle Bu Teaching Hospital in the southern part of Ghana. It has a good number of burn survivors active. Although this is a great initiative, it is only accessible to those within close proximity to the hospital, as travel costs can also pose a barrier. It is my belief that the most important thing NGOs like Beyond Burns International can do is create awareness. The more noise we make, the more others can become aware of the situation and contribute to the solution. In addition to this, we must continue to educate on causes and prevention of burns and advocate for better health coverage for burn injuries, including better equipped and manned health facilities and community acceptance of burn survivors. Where we can continue to financially support some survivors as they navigate the journey towards rehabilitation. Lastly, I'm happy to be part of this unified global voice. Congratulations to the organizers of this conference. I salute you for taking out time and resource for the cause of burns. Thank you.
Thank you, Judith. And I wanted to thank all three of our presenters for pointing out some amazing points. We do actually have about 10 minutes for questions. I noticed that a few have been answered in the Q&A, but if you do have any questions, please use the Q&A button down the bottom of your screen. I just wanted to just say that the presenters that we've just heard from have highlighted those issues that we started off highlighting at the beginning, which is around obviously a lot of burns that occur, but things that we may not necessarily look at as the obvious need to be considered. Simple resources that can be available. And I think Judith has made an amazing point about the more noise we can make, the more actions we can get out. And I think that's basically what we're trying to do with World Burns Week. We're trying to make noise. We're trying to bring about action. So I do encourage you to ask any questions from these amazing presenters. And I haven't seen any come through. But I don't know
I
whether...
can go ahead and start
Yep.
by asking a couple questions while we are waiting for the Q&A. From our three speakers, congratulations, excellent presentations, and we thank you so much for coming on to speak about this, this topic. I want to ask you how much, I know Shobha just mentioned making noise. How much noise have have you made with the governments in your areas around the world? For example, in Ghana, can you speak a little bit about the governmental involvement in helping with prevention, for example, and in helping with caring of burn survivors, more in depth? Has the government bought into helping with prevention? Judith?
Hi, everyone. Thank you for this opportunity to speak to this subject. In Ghana, we haven't done so well with the noise with burn prevention. I know that Kolebu Teaching Hospital every now and again tries to do prevention, like awareness on prevention, and it's not that loud compared to when we are doing breast cancer awareness or heart disease, you know. So I feel like there's so much we can do, especially with media, because today on the news, I heard that it was Diabetes Week. And I'm like, it's World Burn Week and nobody knows about this. So I feel like we haven't used the media very well to send out the message on burn prevention. It's a good tool to have the media on our side to speak to the matter so that when it's World Burns Week, everybody can attend to it as such. But currently here it's what we are doing currently, trying to make the noise, but I do not see any help. Tomorrow we'll go to the media to try and tell them about what we are doing for World Burns Week here in Ghana, and we'll go on Thursday as well. But I don't feel like it's very loud as expected.
Thank you, Judith. Dorothy, and then Shobha, any comments on this?
Yeah, I completely agree with Judith. There's just not enough government involvement, and we need their help. We need their support. I've been working in Malawi for 2 years now, and the burden of burns is significantly high. And there have been recent efforts to actually try and start up some kind of burn prevention program, but we still definitely need more input from the government to come in and just give a helping hand and just create more awareness, and as well as there has to just be more education of the staff who are receiving these patients, because as Dr. Chamania highlighted, it's very important the first aid that these patients are being given, so that by the time they're referred, they're actually in a pretty good state, and haven't been delayed even at a health center. So there's significant amounts of work that still needs to be done. It's not just for here, but in many African countries.
Thank you, Dorothy. Shobha?
Government was approached by 2010, and much before that, with whatever data was available, with the senior professors available in Delhi. And that is the reason that we had a 5-year plan rolled out for improving the burn care. But unfortunately, this was only the pioneers of rolling out this program were all doctors, all burn surgeons, and none of them were public health workers. So it was more skewed towards improving the management, more on the clinical aspect, and less on the community and the prevention aspect. So I think we need to encourage the public health workers' inclusion in that program, which will change the scene, I guess, in future.
Thank you.
Thank you so much.
Do we have any questions, Siobhan?
We do have some questions. So Chrissy from the UK was asking Judith about how do you make strides towards that acceptance that you were talking about in regards to scarring people with scars in the community, because it is something that we have been looking at. Well, certainly from ANZBAR, we've been trying to look at it. And Chrissy was saying across the globe.
Okay, so in Ghana right now, we have a burn support group. It's something that we are starting at the Korle-Bu Teaching Hospital, where we refer survivors to this group to have emotional, psychological support. And through these, we are trying to encourage each other that the scars are there, it takes time to go away and stuff like that. I have a social media page too that I try to post on burns and everything. And then you can tell that in the comment section that a lot of people are very concerned about their children who have scars and them wanting the scars to disappear because of how they feel about it. The stigma is still there. It's taking time for us to get to a point where people are able to accept you, but we are trying to do that. And there's a lot of education that has to be done. I feel that funding has been an issue. If we are able to educate a larger, community about burns and acceptance of survivors, I think would make headway, just like we've done for deaf and dumb people. At first we used to look at them a certain way when they start expressing themselves like this in Ghana, but now we know that when you get to a shop and you see them that you're not looking at them with education, but we've done the same for burns, I think.
Okay, we're having a little problem with the audio.
We might have lost you, Judith, but I think we definitely got the point that you were making in that acceptance and that, spreading of the information about burns is definitely really, really important. Thank you very much for that.
We do have another question from Tamid, and he's asking the presenters if in your respective areas where you come from, do you have any legislation about burns prevention? Has any?
No, we currently don't. And we don't have a specific burn awareness day.
I might answer from a Fiji point of view. Just I know Semesa is not here, but he sits on the ANZBAR Prevention Committee, and Fiji actually joins in with the Australian New Zealand Burn Awareness Month. We actually have a month, which is very, very long, but they do a lot of work. They actually go out into the communities and they go to churches and spread information out in any way that they can. So there's a lot of amazing work, but we definitely do need to have more government support across the world, I believe, for these sorts of initiatives.
Absolutely. And if I'm not mistaken, there are some countries around the world that have been successful in implementing legislation with the governments. Colombia, for example, I believe they've done really well with legislation on acid attacks. So I think we need definitely, like you said, Shobha, more and more of this. I think we have a minute or two for some other questions.
Yep, so there's a question from Marco Aurelia Lizarraga Celaya. My apologies for my pronunciation, rubbish. To Dorothy, what kind of solutions have you found to solve the lack of skin graft treatment in Africa?
Yes, so as you noted, we also noted that there was a big problem with skin grafting not being performed. And so we did another follow-up study actually to this one to understand what are the possible challenges and this also, again, what are the possible solutions to making skin grafting being more available. And the study basically revealed the same thing, that we need to still, apart from just providing more equipment, we still need to do more education amongst all the participants who did partake in it. Those were their points of view, that there needs to be more education and also more awareness about the importance of doing timely skin grafting. Because surprisingly, it was also surprising to find out that many people, and these were all health professionals, still thought that skin grafting is associated with huge amounts of blood loss. And instead of actually helping a patient, they thought the best thing to do would be basically to give them more time and wait before trying to attempt to excise and graft a major burn. So there has to be, definitely still the key thing here is more education and understanding of why it has to be timely, when to do it, how to do it. And then from there, the equipment aspects can always come in. But if a person doesn't actually understand the indications and understand when is the right time, you can actually probably cause more harm and more damage than good, that the intended good that you wanted to do. So still at the end of the day, it's more education to the right health professionals.
Great. Thank you, Dorothy. We might actually wrap up, but we might ask the three presenters to just make a final comment before we just put up the final slide, if that's okay. So any final comment, Judith, from yourself?
Hi. Can you hear me though?
We can hear you now, yes.
Okay, so no, we do not have any legislation for burn prevention in Ghana, not yet. This is the first time we are celebrating Burn Week. It's never happened. And so I'd want us to focus a lot on trying to push out the message of prevention through the media. I think that we haven't used the media very well, especially because nobody is saying anything about World Burns Week today it should be on BBC. It should be everywhere, I think. But I don't feel like we are putting the message out there, so we should on social media as well. I think it would be a great way to push our message across and then help reduce that burden or incidence of burns we are trying to stop here in Africa. Thank you.
Thank you.
I would like to also just say thank you so much for, this is the first time we're doing this, and it's, we know the amounts of work you guys have all put into this, and we're so grateful that, we know that we're not alone, and there's a huge team across the world who's trying to help improve the current situation that we have. I think at the end of the day, from these talks, I've understood how important it is that we do actually get the government backing behind us, because there's only so much we can do on our own. And also just listening to Dr. Shobha's story of how things started off in India, I think it's a great example of, of what happens when you have so many people advocating for change, and because those are big strides that they have made over the past couple of years. So it's encouraging to see the success story, even though there's still challenges. And hopefully we can also have more stories like that from more countries across the globe. Thank you.
Thank you. Thank you all so very much. This has been a fantastic first day of what promises to be an amazing week ahead. Can we please have the last slide, Natalie? So in closing today, we want to invite you all to attend the sessions the rest of the week. Tomorrow, November 5th, we are discussing the hidden cause from the burden of burn injuries. And we go on Wednesday with common responsibilities, solutions, and commitments on Friday. The sessions are all held at the same time the rest of the week. And the link you have accepted it's been accepted for the entire week. So if you register, basically just go ahead and sign in every day at the same time. Any final words from you, David?
So excuse me. Yes. Well, thank you, everyone. It's been a very rich session. This is the first day of the first year of World Burns Week, and there'll be many more years to come. And but for now, many more days to come. So thank you for everyone who's tuned in from everywhere. And let's call an end to the session. And I hope to see everyone again tomorrow. Thank you.
Thank you so much. Thank you so much. And thank you to Shobha and Connolly from ANSPA for being my co-moderator today. Thank you all. Thank you, David, for everything you've done. Bye-bye.
Thank you for having us.
Yeah, thank you, everyone. Bye.
Thank you.
Thank you.